maybe just to introduce Jane to the group and everyone online. So Jane actually grew up, she just told us when we went to go and grab some lunch in the UK. So she did her medical degree at the University of Nottingham and then went on to train as a histopathologist in London and also do a PhD in London. And then she emigrated to Australia, where she gained her accreditation with the Royal College of Pathologists of Australasia. And now she is the Clinical Director of Pathology at the University of the Sunshine Coast in Queensland. So I think with that, it's a pleasure to have you here, Jane, and
thank you.
Go ahead.
Thank you. Well, thank you. I'm not sure if I invited myself to speak, but anyway, thank you for having me here and hosting me here. You see the title of my talk, Computational Pathology, Diverse Applications from Triple Negative Breast Cancer to Perinatal Death. They are very, very diverse, but they reflect the two interests, one of the two interests I've had over my career as a histopathologist, which has spanned about 30 years now, I'm embarrassed to say. Now, how do I go down?
So I'll just click that,
okay.
And then you should be fine.
So just briefly, right. So this, oh, I'm not very good with this, am I? Here is the Sunshine Coast. That's where I am in the state of Queensland. And the main state capital is Brisbane. Well, the state capital is Brisbane. I work for the public pathology, state-run public pathology of Queensland. And we have labs all over Queensland, including the top up here in Cairns. Now, just there's big distances here. So Cairns to Brisbane is actually further than Brisbane to Sydney. So we do definitely have a distance issue. And with distance issue, there's also things like employing pathologists all over these various places in Queensland. But that's where I'm at. Sunshine Coast is about 2 hours drive north of Brisbane. This I actually got off the internet, but it's a picture of the Sunshine Coast University Hospital. And it's a very nice modern hospital, beautiful buildings, and the sun is always shining in Queensland, as you know. So my talk today is a little bit about the status of digital pathology in Australia, and I'll give you a spoiler here. It's nowhere near as good as in the UK, disappointingly. Then I'm going to talk about my thoughts on a certain type of breast cancer called triple negative breast cancer, and where we're heading in pathology with that, and where AI and computational pathology can help us with interrogating triple negative breast cancer. The tacked on the end, just a little bit about perinatal death and the complexities of investigating perinatal death. I won't spend much time on that at all, but I'm just mentioning it because we as histopathologists who investigate perinatal death really do need the skills of computational biologists to help us pin down causes of perinatal death. And my second last slide, my last one's a little picture, second last slide of my thoughts on how we can integrate CPath into the core business of histopathology. So that's what I'm going to talk about. I know I speak English, I grew up in England, but I do come from 10,000 miles away. And I just want to make sure what I mean by computational pathology is the same as what you mean here. Computational pathology means, to me anyway, and this is how I'm talking about it, digital pathology, which is basically the diagnosing of images, but it's all pathologist interpretation. But computational pathology, I also include the much deeper analysis of the digital image by artificial intelligence, deep learning based interrogation. And that's part of the collaboration that I have been doing with Nasir and his group, including Rowan and her PhD. So that's what I mean by computational pathology. So, okay, that just briefly, how are we going here in Queensland with digital pathology? We do know that digital pathology, image-based diagnostics can really help when you are suffering from distance. So you might think that Australia would be leaders in digital pathology, but I'm afraid to say we're not. But we do have the distance. So if I mentioned our most northern histopath lab is Cairns, and I did a bit of Google searching. Brisbane to Cairns is 1,039 miles, which happens to be exactly the same distance as Warwick to Warsaw. So that's the sort of distance we're dealing with. But if you get to Cairns, you still haven't got to the top of Queensland, which is way up that point, which is called Cape York. That's 1,645 miles, which interestingly is 30 miles short of Warwick to Kiev. So that concentrated my mind, and now I realize why everyone's so worried about what's going on in Ukraine here in Europe. Seems a long way when you're sitting in the Sunshine Coast. All right, so we've got the distance, but I don't know why I put this slide in again, but just to say that we have got histopath labs, Cairns, Townsville, Rockhampton, Toowoomba, etc., and we do suffer from not getting enough pathologists in those more distant laboratories. So what do we do with digital pathology? Well, we do teaching by digital pathology, because we do have trainees and all those sites, and so obviously we can't all come together. So the week before I came here, we got digital images of my slides, which I wanted to teach upon. So we do teaching. There is to some degree expert opinions via digital pathology, but it's very it's very basic, and it's really just showing images through our digital cameras, unfortunately, and then we wait for the slides to come in the post. It's very, very inefficient. The Royal College of Pathologists do send out digital images for our CPDP assessments. That's using something called a Perio image scope software. But there are no digitized anatomical pathology departments, I'm afraid, in Queensland. And that's a shame, because clearly the integration of all the high-end AI and deep learning, it really does require the path labs to be familiar with or have the scope to do digital pathology. The problem is infrastructure costs, on-site IT skills, etc., etc. I have to say that whilst we're certainly not leaders in digital pathology, I believe the standard of histopathology there is very good. So if we can get the leaders, and it could be, you know, I don't know, Coventry and you guys showing us the way that this is really cost effective and it really is going to enhance pathology, I do believe places like Queensland will jump on it once it's been proven by the leaders that it is the way to go. But don't look to Australia to lead the way, I'm afraid. It's, oh, you guys have got to do that. All right, I'm going backwards.
If I can just say maybe, so for those online, we can't see the chat coming in. So if you have any questions, just speak out on for those on Zoom.
All right, so I'm going to change tack now, and I'm going to talk about computational pathology involving artificial intelligence, deep learning based image analysis. And that's
Simon.
Yeah.
Sorry, no questions so far, but David has asked if we could use a laser pointer, the kind of PowerPoint based laser pointer.
That's fine. Laser pointer. I'm not sure
So
where it
I
might
just
be.
do
Thank you.
that.
Yeah, I can see it now. Thanks.
Okay.
Yeah, that's fine.
Well, I'm changing tack and just talking about the artificial intelligence. This is a picture of the bottom of my garden with this very intelligent chap here who is a kangaroo, but he's hiding. Anyway, yeah. So what I'm going to talk about is two things: breast cancer and a little bit, just bear with me, of perinatal pathology. That's just a little bit at the end, but particularly I'm interested in breast cancer. Basically, my interests in histopathology are breast cancer, gynae cancer, lung cancer, and placental pathology. But I'm going to talk about breast cancer. So if you get into the headspace of a pathologist who has got a breast cancer to report, the way we communicate with our clinicians is through the pathology report. And all that is writing down a set of prognostic and predictive markers on which therapy is based. Of course, we discuss at the MDT, but this goes out there and it's there for prosperity. But you'll see up at the top there, breast cancer type. Now that's very, very important. There are size of lesion, cancer grade. These are all other prognostic and predictive markers. But we have stuck with the breast cancer type because it tells us an awful lot, and that's all about morphology. So if you go to the latest WHO classification of breast cancer, you'll see that there are different types of breast cancer. This is purely morphology based. It's nothing to do with biomarkers. So, you know, in this world of what I call soundbite biomarker pathology, you know, why do we still keep these morphological identities to breast cancer? And the simple reason is that they tell us a huge amount about the cancer. So this is called no special type cancer. That's because we can't find a special type to put it into, but you know, that's pretty obvious. This one is a lobular cancer. It is the most common special type. I can look at that and I can call it a lobular cancer whose characteristics are that the cells don't, these are the cells here forming single cell files. They don't stick together. I know that the molecular driver of that lobular cancer is loss of E-cadherin or malfunction of the E-cadherin protein, which causes cells to stick together. Okay, but it goes further than that. I can look at that lobular cancer and I know it will express estrogen receptor, probably progesterone receptor, but not HER2 overexpression. And that's important because what we're trying to do is give the most accurate report. And there's all these checks and balances. So what I'm trying to tell you is that the morphology tells me an awful lot. And I'm not going to chuck that out the window just to give you biomarkers, because the morphology is telling me more than just biomarkers.
That's a question.
Yeah.
So if for example, you can, if you know that may not express the HER2 protein and it may express ER and PR, what would the need for IHC be?
Yeah, because you need degrees of certainty. Yeah, I mean, you know, if you didn't have IHC, there's a certain type of, there is a special type of lobular cancer called pleomorphic lobular cancer, which does sometimes express HER2. That one isn't a pleomorphic lobular carcinoma, but I suppose it's just degree of certainty. You know, if you've got a woman with breast cancer, you just like to value add certainty as you go and you go. But to be honest, if that was ER negative on my immunohistochemistry, I'd ask the lab to repeat it. It's more that I would say that is a false negative. So the morphology just equally this is a tubular cancer. If that comes to me with a slide and it's ER negative, I wouldn't believe it. I'd send it back to them. It's just that I'm trying to convince you that the morphology is the final representation of the molecular drivers of the cancer and in fact the host response. Okay, so that I'm with you guys. The morphology is much more important than anything else. You know, we add on the biomarkers just to confirm what we knew already with the morphology, but because the oncologist can relate to biomarkers. But yeah, so there are different types. So my point is we haven't, despite being in the molecular era for interrogation of breast cancer, we haven't chucked out morphology because it is telling us an awful lot. It's telling us of the molecular drivers, it's of the host response. Yeah, so we keep with these morphologies of breast cancer. So I was just talking about one other very important morphological analysis of breast cancer is the grade, and I'm sure you're familiar with grading. And in breast cancer, we look to see whether they form tubules, This cancer is high grade. It hasn't got the molecular wherewithal to even try to form tubules. This one has. We also look how frequently the cancer is proliferating by a mitotic grade by looking at the mitoses and also the degree of atypical mitoses. So the morphology is really important. We've been doing grading of pathology and the same grading system, grading of breast cancer using the same grading system since way back 1987, and it has stood the test of time for outcome data. All right, so to go further into why I'm absolutely convinced that the phenotype, as I call it, that's the that's the morphology as I see it down the microscope, is very important because it's telling us what the molecular drivers are. Oh, now we've got an echo. Can we see that?
Yeah.
Oh, there we go. So this paper, which is published way back in 1998, I'm not sure if you guys were alive in 1998, but published way back then. That was one of my papers. This is when I was at the Peter MacCallum Cancer Institute in Melbourne. And we were one of the first hospitals in Australia to have a family cancer clinic, which included breast cancers. And we as the pathologists, you could only get referral to that clinic if you had 4 or 5 first or second degree relatives with breast cancer. So we were looking at a very skewed group of breast cancers, I admit that. But we as pathologists looked at all the cancers that came to, well, the cancers that belonged to the women who came to that clinic. And we could just tell by looking down the microscope whether it would be a BRCA1 germline mutation or a BRCA2 germline mutation. This is the picture that we saw all the time with the BRCA1 mutations. These are actually what are now called basal type breast cancers. They were sort of very circumscribed cancers with a pushing edge. This is the cancer cells. This is the stroma. They had high nuclear grade, lack of tubules, etc., etc. So quite early on in my career, I was absolutely convinced that the morphology told us the driving molecular, the molecular drivers of the cancer. Now, okay, that's a setting of a high-risk breast cancer predisposition family. So you've sort of knocked out most of the environmental factors, but nonetheless, in that cohort, you could look down the microscope and predict that they would have germline BRCA1 mutation in that particular cohort. Then in 2000, we're going back a bit with the history of breast cancer, but it's important to understand where we as pathologists, why we've arrived in the here and now. Back in 2000, which is ages ago now, Chuck Perot brought out this seminal paper titled The Molecular Portraits of Human Breast Cancer. And he determined by expression arrays, and he only looked at about 64 breast cancers, but by expression arrays, there are 4 different types of breast cancer: luminal A, luminal B, HER2 enriched, and basal-like breast cancers. And that was good because luminal A and luminal B expressed ER, and therefore they could have hormone therapy as a targeted therapy. HER2 enriched, of course, could have HER2 therapy as a targeted therapy. And then we had the basal-like breast cancers, which didn't express HER2 and they didn't express ER. So they didn't really have any targeted therapy. Now, what happened then is everyone got really keen on these molecular subtypes of breast cancer, partly because it defined different types of breast cancer which had different targeted therapies. And because these basal-like breast cancers, which were called basal-like because they expressed basal cytokeratins, because they didn't have a target, i.e. ER or HER2, when we looked at the ER, PR, and HER2 by immunohistochemistry, they didn't express any of that. So basal-like breast cancers in the path lab came to be synonymous with triple-negative breast cancers. But remember, this is based on 64 breast cancers, including all spectrum of breast cancers. So that's why it's a little confusing because, I'm sorry. So what we have is basal-like breast cancers as defined by expression arrays and triple negative breast cancers as expressed by immunohistochemistry. And it's very true that the majority of triple negative breast cancers are, basal type breast cancers. You see this thing in the middle. So the majority of triple negative breast cancers are basal-like breast cancers. They're in this bit. But there are triple negative breast cancers which aren't basal type breast cancers. They don't have the molecular signature of basal cytokeratin expression. And there are some basal-like breast cancers which, if you slap them on expression arrays, they'd come out as basal-like breast cancers, but they're not triple negative. They might express ER. So that's one of the problems with this concept of triple negative breast cancer. Everyone thinks they are the same disease, but there are different types of triple negative breast cancer. And so through the years, people have taken much larger cohorts of triple negative breast cancers. They have analyzed them by expression arrays, and there's basically 4 types of triple negative breast cancers. This chap, Lehrman, in 2011 published 4 types, which he called basal-like 1, which had, by expression array, cell proliferation and DNA damage repair aberrations. Basal-like 2, which was very similar, but they also picked up an awful lot of immune modulation RNA expression arrays. So that was similar to the basal-like with the DNA damage repair, etc. But they also had an awful lot of immune signaling. And then there's something called mesenchymal, it's M there, mesenchymal, which had expression pathways which seemed that epithelial was transitioning to mesenchyme. It's something that we see in other types of cancers as well. And the last group was called luminal androgen receptor, which actually were more molecularly like luminal A, the ER positive breast cancers, but they didn't express ER, but they did express androgen receptor. So my point here is that if you do expression arrays on your triple negative breast cancer, they're not the same type of breast cancer. Now, why is that important? Because remember, we don't have a targeted therapy for triple negative breast cancer. And if we treat them all as one breast cancer, we're not going to have a targeted therapy that works for all of them, because they all have, there's probably 4 different types which have different molecular drivers. So you'll see here the basal-like, this is Lehrman's basal-like 1, DNA damage response, cell cycle repair, and they seem responsive to PARP inhibitors or platinum-based chemotherapy. Now this one over here, what's called immune modulating, yes, they have similar features as the basal-like breast cancer, but these, because they have an awful lot of immune cells admixed with the cancer, they're probably going to be amenable to immune checkpoint inhibition, the PD-L1 therapy, and so on. The rarer mesenchymal type, maybe you can, so these have been analyzed now by expression arrays to find molecular drivers which are potentially targetable. So you see some, they've suggested MET inhibitors, et cetera, for mesenchymal. And the luminal androgen receptor, probably not surprisingly, maybe androgen blockade, and so on and so forth. So, okay, so that gives us a problem in the diagnostic lab, because are we supposed to now do expression arrays on all our breast cancer? And I can tell you, we ain't got the money for that. So this is where the morphology comes back in. Now, I can look down the microscope and I can recognize a basal type breast cancer. So that would be the one that you'd like to give PARP inhibitors or platinum-based chemotherapy to. I can describe, and the description is on the right of what a basal type breast cancer is, but I've learned from experiences, if I go through that, everyone will fall asleep, but like just I can, you know, there are things there which tell me that's a basal-like breast cancer. So the morphology is telling me the molecular drivers of that cancer. If you look at this next one, rarely, these aren't the most common. The basal type breast cancers are the most common triple negative breast cancer. This would be a mesenchymal type breast cancer. I was trying to describe that by genetics, you have this thing called epithelial mesenchymal transition. And what it means is that these little blue dots are the cancer cells, and they form this chondroid matrix around them. So it's starting to look a bit sarcomatous. It's sometimes called metaplastic breast cancers. It's a subtype that we do recognize in the WHO, metaplastic breast cancers. So we can look down this isn't a normal basal type breast cancer. I can look at that and say, hey, there's something different about that triple negative breast cancer. And I think this is likely to be a mesenchymal type breast cancer, also known as by the pathologists as a metaplastic breast cancer.
These neutrophils?
No, those black things, that is just a poor picture, I beg your pardon. They're the tumor cells are those things, and they're surrounded by all this matrix, almost like it's a cartilage. This is sort of cartilage matrix. So the concept of a metaplastic cancer, whether it's here or the lung or colon or whatever, is that it's changing its appearance from being epithelial to mesenchymal. Anyway, you can look at that down the microscope, and it's not a standard basal type breast cancer. I know it's triple negative because we've done the biomarkers, but that would be a mesenchymal type breast cancer. Next one, yes.
I think Mohsin's got a question online, so he's raised his hand. Mohsin, go ahead.
Yeah, thank you, Simon. It seems that from the discussion that sometimes pathologists can understand the molecular subtype by looking at the morphology. Is that right? And why this is not done usually in the pathology practice?
That's a very good question. Well, we do to some extent. So I'll tell you something that I'm just going to mention this in detail a little bit later. These days, with a triple negative breast cancer, we usually actually give something called neoadjuvant chemotherapy. But I know that works primarily for basal type triple negative breast cancers. So I do say to the clinicians, look, this is a triple negative breast cancer, but it doesn't look like a basal type breast cancer. I don't know, I'm not sure that the neoadjuvant chemotherapy is appropriate in this case. I don't think I've answered your question, but the problem is we need clinical trials to show us that I can look down the microscope and pick the molecular driver. I mean, I can't pick all the molecular aberrations in that cancer because some of them are irrelevant anyway, but you can look at the molecular driver. You can try and recognize the molecular drivers. We just need, I mean, there are publications out there. If you look at that first picture I showed of the standard basal type triple negative breast cancer, the Nottingham group have shown that they've looked at the morphology, they've done the expression arrays, and they do show that they correlate. I don't know why. My opinion is that our clinicians that we talk to relate much easier to a sort of something that goes in an analysis and spits out a specific answer, like it's ER positive, it's PR, it's HER2 positive, or 10% HER2 positive, or something like that. I don't know. I don't think I'm answering your question very well, probably because I don't know the answer. But on the other hand, because we don't have access to expression array analysis of all of our breast cancers, we have brought knowledge from expression arrays back into morphology. So for instance, as I mentioned up front, I know that a lobular cancer should be ER positive. So we sort of use all the data. But I don't know. I don't know why we don't just look at it. I suppose that we're not 100% confident just by looking at it. We can tell the molecular We need, you know, these layers of certainty. I don't think I'm answering your question, but we need layers of certainty. You know, I've been looking at breast cancers for 30 years, so it's probably unfair. I do know we've got a brand new pathologist in my department, and I show him things and he looks at me as if to say, how does she know that? So maybe it's, you know, I've been looking at it for so long with the molecular backgrounds. Yeah. That's a pretty rare one. Yeah. So yeah, if you think about triple negative breast cancers, they're about what, 15% of all breast cancers. And then the majority of triple negative are basal type breast cancers. And then you get these funny ones, which are rare. So, you know, but, you know, I see weird cancers from time to time. You know, things just can be a bit weird from time to time. But this is well recognized. It's just pretty rare compared to other types of breast cancer. But then when you're talking about breast cancer, it's a very common cancer. So, you know, you do see them. Yeah, you do see them. But they're pretty rare compared with all the other types of breast cancer. This was just a picture of luminal androgen receptor. Actually, we talk about apocrine morphology. These cancers have apocrine morphology, which is something which just means that they've got a lot of pink granular cytoplasm around their nuclei. They actually look rather like HER2 positive breast cancers, but of course you get your IHC back and they're HER2 negative. This particular case I did slap on. I borrowed from our prostate pathology friends the androgen receptor immunohistochemistry, just to prove what I thought it would be by looking down the microscope. And in fact, these brown dots do show that it is androgen receptor positive. So, you know, the morphology is very important. And this last one, the morphology is that of a basal type breast cancer. You know, I could go through it again. Sheets of highly atypical cell with large nuclei, abundant mitosis, etc. But look at all these little dotty things on the outside, the lymphocytes. So this is telling you two things. It's telling you the molecular drivers of that cancer, but it's also telling you that that host is mounting an immune response to that cancer. So that's very important because that can be manipulated by immune checkpoint inhibitors. So, you know, again, down the microscope, you can understand the molecular drivers of the cancer, but also you can see what the host's response is to that cancer. So, if you go, so that's, you know, bringing me back to my pie chart. Most triple negative breast cancers are basal-like, but there are triple negative breast cancers that are not basal-like. And then if you see here, there are basal-like breast cancers which are not triple negative.
It seemed like we just had a chat pop-up from Saad online. So Saad, do you want to ask that question?
Right. So when you said in, I think 2 slides back, that it comes back HER2 positive. So when you say HER2 positive, are you talking about those absolute numbers, or now there are new classifications like ultra low HER2 positive, etc.?
I'm sorry, maybe you misheard me. I said it looks like it should come back as HER2 positive.
Sorry about
but it comes back as triple negative. So HER2 negative, including HER2 negative.
So even when you say HER2 negative, is it like you are absolutely sure it's not like this new ultra low kind of category that we don't have much idea about right now?
Well, we could go down the whole rabbit warren of what is HER2 positive, what is HER2 negative. I mean, when we say HER2 negative, what we actually mean is that we have optimized our immunohistochemistry to ignore the usual expression of HER2. And we've optimized our immunohistochemistry only to detect overexpression of HER2. So if I've got, you know, down the line, I've given these talks. If you fiddle around with your immunohistochemistry, you can get a HER2 negative cancer to look like it's HER2 positive just by, changing the retrieval, the antigen retrieval, changing the antibody concentration, etc., because HER2 is actually there. It's just on a normal breast epithelial cell. It's just low expression. And we're only interested in overexpression.
Okay, thank you very much.
Can I ask a quick question?
Yeah.
So, Jane, you mentioned that you can probably see and tell if a tumor is ER positive or HER2 positive and so on. Do you know if you can tell like various combinations of positivity from looking at morphology?
Usually not. I tell you what, that when there are different clones within a tumor, it's usually when we're talking of an advanced tumor, advanced cancer. And all the rules that I'm talking about, all the, the classifications is what is usually on early breast cancer, because there's no doubt about it. As a cancer becomes late stage or, large late stage, been there a long while, you start to get subclones emerging, and they're not really, and we don't know whether it's just irrelevant or whether it's driving that clone or whether it's just aberrant expression of something that is just irrelevant to the actual growth of the tumor. And that's been shown. Things like, comparative genomic hybridization. When you get early cancers, they tend to have relatively limited, well, that detects amplification and deletion, but the sort of later stage of the cancer, they have that, but then they have other things on top, other molecular aberrations on top. So it's sometimes you see what we think is collision tumors, and then you can see different morphologies. They're actually called mixed breast cancers, and there's a definition of mixed morphology breast cancer. And yes, yeah, it gets all rather muddy when you're seeing different areas of it. But actually, my next slide is, can I, Nasir, go on to this next slide? It might.
Sure, of course. No.
Yeah.
I was going to ask another kind of related question as well. Is it just the mutations in one particular gene that can have an effect on the underlying morphology, or could it be a combination of mutations that can also have an impact on morphology?
Yeah, actually, if you think, if you go back to that molecular drivers of breast cancer, if you think about luminal B, they are not really, so luminal A seem to be firing off that estrogen response pathway. And of course, the HER2 are firing off the main drivers at HER2 overexpression. The luminal B have got a variety of pathways which seem to be both estrogen response pathways and perhaps HER2 pathways. So they, we've got so far with molecular interrogation, but we can go for, in fact, we can probably go further down to, individual persons' cancers. It's just, where do you stop on this interrogation of breast cancer to become, to become actually workable? I mean, I presume that's where precision medicine will go, but, we're a million miles from that at the moment. This cancer here up on the screen, I can look at that, and that has got all those morphological features of a basal-like breast cancer. And it was a young woman with a large cancer. And this is really what worries me. There was, and this is a subset of it, there was an area which is ER positive. And we have a cutoff, we say arbitrarily 10%. If you've got more than 10% of your cancer is ER positive, it's an ER positive breast cancer. And that really worries me, because that's going to be rubbish. This is a basal type breast cancer with some spurious ER expression. And what worries me is now there's an absolute dichotomy in the algorithm of treatment, so that if you're ER positive, you get hormone therapy, and then you go on to, you get an excision, and then you go on to hormone therapy. If you're triple negative, you have neoadjuvant chemotherapy, and then you have your excision, and that's a better thing to have. So, and actually the molecular investigations show that if you are less than 10% ER positive, you probably do not respond as an ER positive breast cancer. So the problem is that you can sometimes get over 10%. What do you do for those? But I've actually also, on this cancer, I also did basal cytokeratins, and it's screamingly positive with basal cytokeratins. So I suppose, so this would fit up here, basal-like breast cancer that's not triple negative. So what I'm trying to explain is that we need help to try to sell to our clinicians that the morphology is more important than the biomarkers.
Well, this is the problem from when we try and binarize. You always have to have some threshold somewhere. And yes, we have to talk about this patient for content. But if someone is 9.95,
if there is a question from the audience within the room, we can't hear it online completely.
I mean,
I guess
yeah, the question is, okay, I'm giving all these classifications, and isn't it just a problem of trying to binarize what's probably a biological spectrum? And it is a problem, but it's what our clinicians want. They want, yeah, they want, you know, it's simple for them, and it's simple for them to tell. You can put it into a bucket, and you can explain that to the patient. Can you imagine trying to explain morphology to a patient? Oh, look, we do, you know, you can imagine we saying we're withholding hormone therapy because whilst we've got 11%, the pathologist says it's got pushing margins and all this sort of stuff. They're just not going to relate to it. So that's why we have a problem with morphology, that we can't give percentages. We can't quantify. We're looking for quantification.
So you want to be able to quantify the morphology?
We do, which is why I'm probably sitting in this room. And Nasir has told me this a million times, I'm no good at quantifying, and I agree with him. You know, I can quantify the extremes, but I can't quantify the middle. I can't. And yet you have stupid things like PD-L1 in lung cancer. If it's 50% and above positive for my PD-L1 IHC, they will get Keytruda, the immune checkpoint inhibitor. If it's less than that, they won't. And I'm saying to them, you know, 50% is bang in the middle of this spectrum. So I always put it up to 55%, even if I think it's about 45%. I don't know. I'm going to give them the benefit of the doubt. It's not very scientific, is it? Musing on all that morphology and how we really need help to analyze and present the morphology to our clinical colleagues better. And that's where we set up this collaboration between Nasir's group, including Rowan's PhD. At the time, I was at Westmead Hospital, and one of my colleagues there, Dr. Dinley Graham, and another tissue pathologist, Nirmala Pathmanathan. And Dinny had this group of triple negative breast cancers as part of the Australian Breast Cancer Tissue Bank, which all had a digital image of the cancers. We knew they were triple negative. A proportion of those have got gene expression profiling, and quite a large number of them have now gone on to have proteomics profiling. So they're a very useful cohort. And I don't want to talk about the work that has been done because it's been primarily done here, and it's not me, I'm just the pathologist involved. But basically, we are submitting a paper I think to digital, Nature Digital Pathology, entitled Digital Markers of Tumor-Associated Stroma and Tumor-Infiltrating Lymphocytes, which seem to predict survival of triple-negative breast cancers. And by the very clever computational pathology, 2 types of triple-negative breast cancer have been identified. One with a lot of the blue, the dark blue is the tumor cells and the pink is the stroma. And when you have a lot of broken up tumor cells to stroma, that seems to be a poor prognosis compared with sheets of tumor cells with hardly any stroma. And the other thing that seems important prognostically is the tumor infiltrating lymphocytes. They seem to be a good prognostic marker. So I don't want to, and I can't talk about that because it's not my work, but that's the collaboration that I'm involved with. So these are the outcome data that have been submitted as part of that work, showing as exactly what I've just said about tumor infiltrating lymphocytes being good prognosis and a lot of stroma breaking up the tumor cells as a poor prognosis. You won't look in the pathology books and you won't know anything about, they won't talk about stroma. It's not really what we do. Okay, I know I am indeed running out of time, and I think I just have. The thing that is important, and I'm not going to talk about perinatal death, but the thing that now is important, I believe, for this collaboration is the fact that once I diagnose triple negative breast cancer on a diagnostic core biopsy, the patient then has neoadjuvant chemotherapy, so we won't actually see the whole tumor excised. The tumor is no longer there when they have their definitive surgery. This is a tumor on after excision, as used to be, but now all we're getting is these little fragmented core biopsies. So I think one question we have to ask is whether all the work that has been done on triple negative breast cancers from the entire tumor, whether we can actually, whether that translates to finding these predictive or prognostic markers on core biopsies. That's on a high power. They do look more similar high power. I'm aware that I'm running out of time, but the issue with now in triple negative breast cancer is the fact that we are giving neoadjuvant chemotherapy. So as I mentioned, can we use CPath to help stratify triple negative breast cancers into those who will and those which will not respond to neoadjuvant chemotherapy? Because that's a question. Some of them do not respond, most of them do, but some of them do not. And can the studies done so far on whole slide images translate to the core biopsies that we're going to be seeing? Because we're really not seeing whole tumors anymore on triple negative breast cancers because they are being given neoadjuvant chemotherapy and then they melt away. They do come back years later, but they melt away. I think I might stop my talk there because I've been, as I said, I can talk about breast cancer forever, and I don't think that's fair on the audience. So I think I'm going to stop there because I've talked enough. Thank you.
Thank you very much, Jane. Does anybody have any questions in the room?
Yeah. So can I have one general question about the perspective from using core needle biopsies? Because like this is to present some different perspective compared to the whole section things. So what is the current expectation and what is the way for the pathologist to actually diagnose and compare between these two? Do you actually change your perspective or the signature of morphological signature that you want to search for or something?
Might have to repeat that if that's okay.
Yeah.
Because people online might not have been able to hear.
Okay. Right. The question was, so now we are just looking at core biopsies alone of triple negative breast cancer. Can we get, I think it's, can we get all the data that we used to get from the entire tumor? Can we get it from the triple negative? Look, I'm afraid to say that if you think about what the clinician has to do, all they have to do is treat the patient with the most optimal way. So all I need is my core biopsy. I say, yes, there's breast cancer. I put my ER, PR, and HER2 IHC in, and I say, yes, it's triple negative. And then they go on to do neoadjuvant chemotherapy. It's as basic as that. I mean, we talk about precision medicine, et cetera, but that's how we're working at the moment. And you know, the goal is precision medicine. And hopefully we can look in the future at the core biopsies and get more data. But the data we get from the biopsies are actually driven by what the clinicians want. You know, I can get more data out of my core biopsies, but the clinicians don't really need it at current time.
Yeah, so that's one thing. Another thing is that when you look between the corneal biopsies and whole things, do you change your perspective when you're looking for a signature?
Well, the answer is we don't really look beyond saying whether it's ER, PR, and HER2 positive or ER, PR, and HER2 negative. We don't give a formal grade because we don't actually have enough tissue to give a formal grade. I mean, if you think of a mitotic count, it has to be 10 high power fields or per millimeter squared. And sometimes we don't have that amount of tumor. So we don't give, I never give a formal grade on my core biopsies, but the clinicians don't treat based on the grade. So it doesn't really matter. They're only treating on those 3 biomarkers at the moment with precision. So we're a million miles from precision medicine.
Okay.
Yeah.
Thank you.
One question online. So I think we've just got time for potentially one more. So David, he asked a question about 10 minutes ago. So you've talked to percentages and quantities. In a battle, relative positions are important. Shouldn't that be taken into account somehow?
Relative positions of what exactly, David?
Are you still there, David?
Sorry, I just mean, well, you found various molecular properties in various parts of a tissue section, say, and if you just, I'm not sure what the percentages that you were talking about actually mean.
Yeah.
But I'm saying that the percentages may be the relative positions of all of the different components of the tumor, and maybe relative positions of defensive mechanisms around the tumor are as important as measuring these percentages. That's what I'm asking you about.
Yes. We almost sort of have certain hurdles above which, percentages above which the clinician will use the targeted therapy. So if you think about ER expression, if it's more than 10%, they'll get hormone therapy. But also if it's, some cancers are ER positive and HER2 positive. So if I say it's got, you know, ER expression 60% and it's HER2 positive, they will give targeted therapy for both HER2 and hormone therapy. So in general, and I don't know why this is so, 10% seems to be the cutoff. It's the same with the morphology. You call it a mixed cancer if you have more than 10% of one of 2 types of cancer. So for instance, you might have 70% of the cancer has the morphology of a lobular cancer, and the other 30% has the no special type. So you'd call it a mixed cancer because the no special type's over 10%. This is not, you know, real hardcore science. We're just trying to fit numbers to biology. And if we do have targeted therapies, we'll basically give it a go if it's got over usually that 10% threshold, but you know, that might not be an accurate threshold.
But my point is that that digital pathology is in theory capable of relating the morphology in different parts of the tissue section and recommending some targeted therapy on that basis.
Yes, I agree with you. What we have to do, though, is prove, we have to prove the link between what the computational pathology is telling us and actually the genetics which drive and can be targeted in that tumor. And maybe that's, unfortunately, I skipped over it because it was towards the end. This cohort that I'm looking at with Nasir, the Australian Breast Cancer Tissue Bank, that sort of Venn diagram did have the fact that a proportion of those cancers have had molecular expression array done on it, and the proportion has got proteomics. So what we would need to do is, particularly we say with the proteomics, see what portion of the tumor has, what bit of the tumor has been analyzed by proteomics. But we have to, I mean, I don't know, but I don't know that there's many people analyzing triple negative breast cancers by computational pathology. So we very much, first of all, have to find the different types of morphology and establish those before we move on to referencing that with the molecular expression of those areas. I think we're in the very early days here.
Great, thank you very much. So I think with that, shall we give Jane another round of applause? Thank you very much, Jane.
Thank you very much, Jane, for your seminar. Really enjoyed it. Wished I could be there. You didn't talk much about the perinatal death. Is that something that perhaps we're gonna discuss later in the interest of time?
My brief point about perinatal death is we as pathologists, we sort of document what we see and find, but there are so many databases now on genomics, which we just need, we're not computational biology people, we can't deal with databases, and genetics is all now on databases, and so we're stuck in sort of the last century, and we need to link up with people who are involved with the database analysis of these reiterative databases of what molecules give what phenotype, what genetic mutations give what phenotypes, and only then can we actually sort of solve this issue of what causes perinatal death. But anyway, that's another story.
Okay. Yeah, we should definitely, that's really fascinating. We should definitely discuss that in a follow-up meeting.
Yeah.
I would love to.
Thank you, Nasir. Thank you.
Okay, thanks everyone online for joining. So I think with that we can conclude the seminar.